Thank you for joining our second webinar on improving the management of adult COVID-19 patients based on the shared learning from high-performing trusts. My name is Pratusha Babu, and I'm a current GIRFT Clinical Fellow and Paediatric Intensive Care Trainee in London. I was involved in this multidisciplinary cross-speciality project last October with project lead Dr. Anakin Navaratnam, GIRFT Chair Professor Tim Briggs, and our GIRFT clinical leads, which led to the recent publication of this shared learning. Following our first webinar in early February, this second webinar focuses on the data involved and how we're looking to the future of hospital practice. Professor Tim Briggs will open the session with a discussion on the background to the project, followed by our speakers discussing the data and analysis, followed by our specialty perspectives with a focus of future clinical practice with COVID-19. Following our speakers, there'll be an opportunity to discuss any questions with our panel of GIRFT clinical leads from multiple specialties, and I'd encourage you to please use the Q&A box to write questions. I would also like to remind you that the session will be recorded and posted online for later viewing. I will now hand over to Professor Tim Briggs, GIRFT Chair and National Director of Clinical Improvement for the NHS.
So thank you, Pratusha, very much for that. And this is our second webinar on this document that we produced, backed by popular request, I think, and we're delighted to have so many people on the call. Could I have the next slide, please? So this all came about from information that began to seep out into the media in July of last year, which concluded that there was a great variation in COVID-19 mortality rates between hospital trusts. And it gained enough traction that there was a discussion between the Secretary of State, Matt Hancock, and the previous Secretary of State, Jeremy Hunt, about whether the variation in mortality rate could be explained by the variations or whether it was due to other causes. And we were asked that we were in a very good place to investigate this, because this is what we do. And so we thought we could use the GIRFT methodology to rapidly analyse national data, engage with some trusts that were performing particularly well during the COVID first wave, and do that with the support of the specialist societies. And as you know, the GIRFT programme has 40 specialty groups working together currently, and then disseminate excellent practice. Next slide, please. If you look at this slide, this is from March 2020 to May 2020, and you can see there that we have bars on which measure discharges from the hospital, and these are patients who've been admitted with COVID. And you can see the interventions in the blue lines, in the vertical blue lines, around the NHSE Next Steps letter to trusts, which was disseminated on the 17th of March, followed by the lockdown announced on the 23rd of March, and then, of course, the NHSE CPAP guidance published on the 3rd of April. And what is really reassuring to see for me is that mortality rates declined by 16% between late March and May, and mortality rates were already dropping, even though we had significant discharges, which I think demonstrated that all trusts were already working, changing their practice to actually improve the outcomes for patients with COVID. And once you adjust the analysis that accounts for the risk factors, the patient risk factors, it shows that the change in probability of mortality decreased by 33% over this time period, which I think is a great testament to the hard work of all our colleagues in the NHS to learn and actually work out how we to treat this new disease better. Next slide, please. Finally, this is a funnel plot, which everybody will know about, 2 and 3 standard errors either side of the mean. And what you can see there is each little blob there is a trust. And once you take away the known predictors that we know that influence patient mortality, and you consider those, then you can see that the majority of trusts fit within a normal distribution. But what we also found were there were 7 trusts who were below the out of control limits of 3 standard errors, suggesting that they had a very low mortality rates in these trusts. And so we chose 6 of them to do deep dives on with my colleagues, and they were North West London trusts, Guy's and St Thomas's, Bart's Health, Luton and Dunstable, which is part of Bedfordshire Hospitals, University of Leicester, and Lancashire Teaching Hospitals Trust. And so what we set about was organising deep dives with all their clinical leaders who were involved in the treatment of COVID, and our clinical leads who all have been appointed by the specialist societies to their appointments with working with GIRFT, to try and distill how we can improve practice for taking things forward and learning from those trusts. Thank you very much. Patricia.
Thank you, Professor Briggs. Next, I'd like to introduce Dr. William Keith Gray, GIRFT Senior Research Associate.
You see those slides, Patricia? Are they okay?
Yeah,
my name's Keith Gray. I work for the GIRFT programme as a Senior Research Associate. And I'd just like today to give an update on some of the figures that Prof Briggs has already shown you there and are also in the national report. I won't go into the methods in any great detail, but if you are interested, there's this paper which I've just given a link to on this first slide. And that's just been published in Lancet Respiratory Medicine, online first, and it's free to download, so you can have a more detail. This first slide I'd like to show, The first slide I'd like to show shows an update on the situation following on from the national report, which was June to July, and takes us to the end of October. You'll see the mortality rate, which is shown as the red line there, slightly kicks up in October. And I guess the question you're all wondering is what's happening now? What's happening in November, December, January and February? Unfortunately, GIRFT data are taken from only become available about 2 or 3 months after the event. So we have at the moment data for November, but we don't really have any update on that, but we will be updating our analysis once those data become available. But you can see here the mortality rate kicks up slightly in October, and the mortality data were taken from the Office of National Statistics data, which is generally taken as being the gold standard for mortality. And most of the data were taken from the hospital episode statistics database. And we identified the codes based on the ICD-10 codes used. Yeah, so the next slide I'd like to show, just in terms of that little kick up you saw in October, I'd just like to show you how the situation is changing over time. And the point here is that when we consider this analysis, we do need to take into account the change over time. So big changes in age. Initially, age in March was relatively low for patients being admitted, rose steadily into May, and then has been falling really ever since, fell to below 60%, below 70 years towards September, and then again kicks up a little bit in October. And this might be one of the reasons why we're seeing that kick up in mortality rates during October, is because the age profile of patients is changing. And below, the slide below that shows the change in length of stay over the same time period. And you can see there's been huge changes here. Initially, the length of stay, about 4 days, rising fairly rapidly in May, and then falling off, and then just kicking up again a little bit in October. So the point to take from these slides is that the situation is changing, the clinical situation is changing in terms of patient management with the change in length of stay, but also the patient profile is changing as well. And this shows activity by region, again over the same time period. The key points here is that during April, the data were dominated by data from London and to a lesser extent the Midlands. And during October, we see this kick up in the northwest and the northeast in cases. And what I'd like to show as well, that when we're looking at the data, we have to take into account the time period we're looking at, because in the northwest and the northeast, October and moving into November, the number of cases is roughly the same as during the first wave, slightly lower, but it's certainly increasing. Whereas in London, the London data is dominated by the first wave activity, that sort of period in March and April, and less so for a lot of the other regions. And in the southwest, which is the lowest line you can see there, they generally had very low case numbers throughout. If we then look at how mortality is changing by these regions, again, a similar trend, hard to differentiate too much from this. The two take-home points probably here are that red line, which is London, which appears to have the lowest mortality rate generally throughout. The patient population was much lower. So London as a region has by far the youngest demographics for the patient population, much more homogeneous within the other regions. And that top bar you can see, which is the east of England, so you might imagine they perhaps have higher mortality rates. That's because they have a much older age structure. So the southwest and the east of England have much older age structures than the other regions in the UK. So we applied a logistic regression model to all this data to try and tease out all these, what was going on with age over time, what was changing in terms of patient profiles, the changes regionally. And this is essentially what it looks like, and it follows on from what Professor Briggs presented. So we can see in March, mortality rates start off at about 33% for those admitted to hospital once we've adjusted for age and comorbidity, sex, ethnicity, deprivation, and time as well. And then the vast majority of the fall in mortality rates is during this April period, and then it stabilizes, continues to fall during May and a little bit of June, and then stabilizes during the rest of the summer. And this takes us to the end of September, where mortality rates are fairly stable. And the big question will be do they stay slow as we move into the second wave of cases we've had? But the key point here is that the vast majority of that fall is occurring during April period. And although this is likely to be partly due to the lockdown, people having a lower viral load on presentation, as Professor Briggs says, this is almost certainly due to, the vast majority of this will be due to improved clinical management of patients. And it's a fantastic achievement that from 33%, about 12%, which is phenomenal. And this is just a summary of the logistic regression model we ran. The take homes from this slide is probably that age is the dominant effect, which I think we all know. I've printed age and age bands here. Much less so deprivation. So if we just look at those who make it into hospital, we're only looking at the hospital population here. If you look at community-based studies, they tend to show a much larger association with deprivation and with ethnicity than we show. And once you make it to hospital, the risk of mortality for a lot of ethnic groups is actually, there's not a huge difference. We found South Asian groups had a slightly higher increased risk of mortality compared to other groups. Black people had no greater increased risk of mortality compared to white people once they made it to hospital. And the overall effect, even in people of South Asian origin, is relatively modest. And also towards the bottom of the graph is a list of some comorbidities, and most of these had an association beyond the effect of age. Most of the comorbidities had some sort of association with mortality. And this is the effect of age. So if we model age as a linear term, so we look at it as a linear rather than in terms of age bands, this is what it looks like. It's not quite a line, it's a sort of shallow sigmoid curve, we'd say. Relatively low mortality rates in those below the age of 40, and then a steady increase from there on up to the higher age band. So it's a broadly linear relationship, you would say. There's no point at which your risk of death suddenly kicks up. This is an interesting analysis we did. This is a paper that's currently under review in one of the Lancet family journals. We look at the period March to May in terms of the association between mortality for those who made it to hospital and ethnicity. And we divided it up, rather than looking at South Asian and Black groups as a whole, we divided those up a little bit more. And you can see during the March to May period, which is that analysis I've just shown you, the association with the South Asian groups, there's a slightly increased risk of mortality, not so for the Black groups and for the mixed ethnicity groups. Once we look at the June to September period, which is a period of lower activity, and hopefully things had stabilised and all that learning had been done, so that us were in a much more stable position. Most of these associations with ethnicity disappear, except for the group with Pakistani ethnic origin, which the odds ratio increases slightly, so the risk of death increases slightly. We're not entirely sure why that is, and we're going to keep monitoring this as we go forward. It may be an artifact. It may be an artifact, or it may relate to sort of health messaging and so on and so forth. But that's worth looking at as we go forward. And this, Professor Briggs showed you the funnel plot. This is another representation of the same data. And the take-home message from this slide, so each of these dots represents a slide, and the bars, the vertical bars, are confidence intervals around those estimates. And this shows the mortality rate. And the take-home message from this is that there's no huge variation in mortality rates across the trusts. This variation, we see the highest trust there in one of the trusts with about 37% mortality rate, and the lowest is around about 20. But the point I'd make here is that this is normal variation. Looking at this statistically, there is no suggestion there's any outliers here. This is the sort of variation you would expect from a normally distributed population. So there's no, just to emphasise the point that Professor Briggs made, there's no suggestion here that any of these trusts, that any of these mortality rates are undue, or there's any outliers, or there are any trusts that were at cause. And so just to summarise that, so that takes us forward. It follows on from the analysis we did for the national report. And it's just the importance of adjusting for temporal trends, for changes over time. The London data is dominated by this early period, by the people from this early period, whereas a lot of the other data is dominated by the late autumn period. And the situation as regards the role of ethnicity and comorbidity is changing all the time, and we do need to take this into consideration when considering triaging patients. And that's everything from me. Thank you very much.
Thank you, Keith. Our next speaker is Dr. Mike Jones, GIRFT Joint Clinical Lead for Acute and General Medicine.
Thank you. Hopefully you can see my slides. My name is Mike Jones. I'm an acute physician up in Durham, and with Philip Dyer, we've led the acute and general medicine work stream in GIRFT, and we've been asked to look at what future hospital clinical practice in acute and general medicine with COVID-19 might look like, based on the experience we've had of going around many of the hospitals within the UK, trying to make sure that we have a good picture of how we're moving things forward. I'm having a difficulty in moving my slides forward. Don't know if I can get any help from anybody on this.
David, can you share the slides?
Are we on to the second slide?
Yes, Mike.
Yes.
Yeah, okay. The uncertainties associated with COVID, and I apologise for the hesitation, are undoubtedly associated with what COVID-19 has brought us and how it will continue to modify. With the mutations that we are aware of in the spike protein, and therefore the effects this has on vaccination and the continued herd immunity, we're not going to be clear for some time whether the vaccination program will lead to a decrease in a long-term presentation of COVID-19 to the acute hospital, or indeed whether it will affect the acuity of illness. Obviously, the stuff we have at the moment shows that we are doing better, and long may that persist. But I think everybody acknowledges that COVID-19 will be with us for some time. However, we do know as well that long COVID, however that will present in the future, is going to have some effect. Again, the precise pressures that this will bring is unclear. It is also very apparent as we are coming out of the major effects in the hospital sector, that untreated medical illness is starting to present. It had been a long time since I'd last seen a florid pulmonary edema, but as patients have kept themselves away from medical follow-up, then we're seeing more patients presenting with illnesses or chronic exacerbation, acute exacerbation of chronic illness that has previously almost disappeared and is now representing. And this is going to be different across the whole of the UK because of the disparate geographic effects of the pandemic. Some areas having very minor effect from this, and as Keith has shown, London had significant impact from COVID-19. And of course, we need to acknowledge that there were differential effects on the workforce right across the multi-professional teams, where people were becoming exhausted and themselves having the effect of COVID-19 when many were becoming infected. It's fair to say that acute medicine pressures have pretty much returned to their normal levels, and on top of this we have COVID-19. So the pressures on acute medicine are very real. Could I get the next slide, please? So we need to try and make sure that our management of patients is as effective and as streamlined as possible. And we've been surprised when we've been going round acute and general medicine services that there are very specific deficits in how people are managing patients and very, very significant variation. So actually getting the patient to the right place for their needs and doing that first time is critically important. We recognise that there needs to be an increased use of an outpatient setting, and in particular, the same-day emergency care setting for patients who would not need hospital admission. But we've also got to look at how patients are being managed in the community and developing anticipatory care pathways, but those are only effective if there is support within the community to provide sometimes end-of-life care, but also managing patients in a far better way so that their acute exacerbation of their chronic condition can be managed appropriately. And to help with that, we do believe that there should be accessible consultant opinion across the generalist medical specialties and also those specialties who can provide better advice and indeed outpatient access. So patients, again, don't need to present as an acute emergency, but their chronic condition is managed optimally in the community. But even with an assessment, when patients do present to the front door, there are now multiple validated assessment tools. Some of these are listed here, and yet they are frequently not used to try and determine where the patient is best managed and how they're best managed. We know that the patient age groups and those presenting to acute care are generally increasingly frail, but many hospitals are still not using frailty assessment, and that is a critical part of how we determine how we can get patients home again. And again, COVID has shown us that the need to anticipate where escalation plans and DNA CPR notices should be, frequently we're still finding that they're not being implemented appropriately. These are all aspects that can help us manage patients on an individual basis and trying to ensure that they are given the optimal care. Next slide, please. Within the streamlining process, it is important that we ensure that there is rapid instigation of management and treatment plans, and that has to include the availability of investigations. When we know that delays for most medical conditions do not benefit the patient, we have to ensure that the investigation pathways are smooth and readily available. And of course, there is no point in doing an investigation unless there is a prompt review of the results with an aim to discharge the patient whenever possible. And the discharge to assess, bringing patients back to an outpatient setting when that's possible, is far better than keeping them in hospital. And I think we have proven this during the recent pandemic due to the nosocomial rate of infection with the virus. And there, of course, needs to be adequacy of MDT staffing to meet demand times. Frequently, we've found that the staffing is not geared to where there's greatest demand. And there has to be early involvement of consultants to ensure that the management plans that are developed are appropriate to the patient need. Again, that is only just beginning in some hospitals, and we need to recognize that that truly can help. Next slide, please. And moving on, how do we do this? It is important that you understand your own data and the effects of COVID on the locality, both in terms of your workforce and your community. To do that, you have to collect your own data and make sure it's reviewed for accuracy and understand what it shows, because that way you can manage your staffing levels and anticipate where patients will require care. Review the pathways for the common and high volume conditions and ensure that they're consistent and robust, but collaborate within hospitals and with the community services to manage the bulk of patients who have a chronic condition and therefore will get acute exacerbation. We need to make sure that staffing and investigation is always relevant to the needs of the patients and tackles the patient demand. These are all critical aspects that can be undertaken in every locality. Thank you very much for your attention, and we will now move on.
Thanks, Mike. Our next speaker is Dr. Mike Swart, GIRFT Joint Clinical Lead for Anaesthesia and Perioperative Medicine. Thank you.
Thanks, Patricia. A joint lead with Chris Snowden, who unfortunately I don't think is with us today. So at the same time that we were doing the GIRFT review of COVID outcomes, we also started to look at what we knew would become a problem as we started to come out of COVID. And that's the huge surgical backlog that's built up without our ability to provide a normal service. In addition to that, there'll be a backlog of patients referring to their GPs and a backlog of patients who have not been able to get into the screening programs. Next slide, please. I've got 2 slides and 4 topics. The first thing to mention is there's a title of a poem written by Damien Barr. We're in the same storm, but in different boats. And what I'm using that to refer to is the staff or the healthcare community and social care community that's been dealing with COVID have not all had the same experience, and we need to be cognizant of that. For example, you saw an earlier slide how different parts of England were more or less affected by COVID, but then there's also within, say, a hospital, different parts of the hospital have been more or less affected. And I would suggest that ED, acute medicine, theatres, ITU and anaesthetics bore the brunt of COVID in the hospital sector. I'd like to draw your attention to, if you Google the King's Fund COVID-19 Recovery and Resilience, there's a very good document that takes from the experience of natural disasters about the mental health and well-being of people after disasters. Second point I want to talk about is we recognised very early that day surgery was going to be a key way of recovering for this surgical backlog. 2 reasons. It reduces the demand on hospital beds, but also patients don't want to be in hospital during COVID. So working with British Association of Day Surgery, Centre for Perioperative Care, we drew up a best practice guide for day surgery. And I'd like to acknowledge that Mary Stocker, an ex-BADS president, was the main author, but there were many other people who improved and polished the document. So if you want to know how to deliver day surgery, that's where you go. Next slide, please. The other two areas I'd like to briefly mention were, first of all, elective inpatient surgery. Again, at the same time that we were doing the COVID GIRFT document, we were also looking at something called enhanced care. Now, enhanced care is the provision of ward-based care with something extra. And that something extra could be an arterial line, a vasopressor infusion. And we think that we're going to have big problems with cancellations of particularly high-risk surgical patients on the day of surgery. And if we develop this new way of working called enhanced care, which is on the screen here with two documents, one that came out in March of last year and the other that came out in October. And these give you a route map of how you set up enhanced care. At the same time, we need to provide enhanced recovery to get patients better sooner. And then the final thing to comment on is we're soon to publish the Anaesthesia and Perioperative Medicine GIRFT report. And some of the things that are in that will also, I think, help to impact on the surgical backlog. The first is we've highlighted the well-known variation in length of stay after a hip fracture. So when Chris and I did our visits a bit over a year ago now, the mean length of stay after a hip fracture was 19 days. And the sort of best, or the people with the shortest length of stay were around 13. Now we know that's got better. Now the best practice is around 9 days. And then finally, in the same way that we need medical ambulatory pathways, we need surgical emergency ambulatory pathways to get people home sooner and keep them out of hospital. Thank you very much.
Thank you, Mike, and thank you for the speakers for such insightful presentations. Thanks also for the questions asked, and I'll pick a few key ones for our panel, where we have joining us, in addition to our speakers, our clinical leads for critical care, Dr. Anna Batchelor, for emergency medicine, Dr. Chris Moulton, for respiratory medicine, Dr. Martin Allen, for acute and general medicine, Dr. Philip Dyer, for geriatrics, Dr. Adrian Hopper, for diabetes, Professor Jerry Raymond, and for anaesthetics and perioperative medicine, Dr. Chris Snowden. So I think the first question, if I could pose for Professor Briggs as a follow-on to Mike's presentation just now, and perhaps also some insight from Chris Snowden. So looking to the future, could you provide insight or development of GIRFT work in recovery, recognising that for many of our audience, COVID-19 is still currently a large part of clinical practice?
I think I'll just start, and I think the idea of the GIRFT programme in its totality, which I think feeds very much into COVID, is to use data and clinical practice and then expert clinicians to use that data to drive better practice and better outcome for patients. And that's what we've tried to do. But this document is the first document that we've produced. And I think Keith has already shown his data, how things have changed since then. And therefore the document will be changed and updated as we learn more about this disease. But I open it up to my colleagues. Chris?
Yeah, hi. I'd just like to say sort of reiterate what Mike had said in terms of what we saw before COVID happening and what we've actually shown, what Mike presented was around elements of care that were already there but weren't utilised in the best possible way. So enhanced recovery, for instance, we know that only about 30 or 40% of inpatient surgical patients get put on enhanced recovery pathways, although we know enhanced recovery is a very useful way of reducing length of stay and getting patients to recover quicker. Day surgery, again, huge variations before COVID. And a lot of the time day surgery is something that people stop during winter pressures, or particularly in COVID. It's the first thing that goes, but actually it's probably the greenest pathway that we have. And therefore, day case surgery is something that really needs to be looked at. It's something in terms of about 65 to 70% of our caseload in terms of surgery. And so if we're not doing that correctly and well, and efficiently, then we do lose a huge amount of throughput and capacity. So I think these are things, apart from enhanced care, which Mike spoke around, which is a new sort of facet of how we might deal with, although there are various elements of that occurring already. But that's a new facet of care that we probably need to bring in. But I think most of these elements have been there. There are good sort of best practice examples, and we should be using these as we go forward to look at the backlog.
Thank you, Prof. Riggs and Chris. For the next question, could I invite Anna Batchelor and Martin Allen just to expand on an answer that Mike Swart has already given. Question from Daryl Tapakeri. Within ICU, we have seen a change in emphasis in respiratory therapy from early advanced respiratory support to basic respiratory support. Does the panel think this is an improvement, and what is its significance? Perhaps we can start with Martin and then Anna.
Thanks very much. I think this has been a fundamental change, and we've seen this evolve over wave 1 into wave 2. And all of the 7 sites that we visited had well-established respiratory support units. And I think that's the marker of why we perhaps found a better mortality, other factors as well, but it reflects a better organisation. And I think as we've seen wave 2, respiratory support units have been a fundamental development. They've existed in all organisations. And I think they've made a significant impact in reducing the number of people that have needed to go to critical care. So I think it has been a fundamental shift. And as Mike said, this is almost like an enhanced support service. And we hope this is the legacy of COVID, that such respiratory support units will be maintained. Anna, I don't know if you want to follow that up.
Yeah, I would totally agree that we've seen some really fantastic developments. Respiratory medicine has stepped up as much, if not more, as critical care has had to do. I think I would say that we probably still don't know when is the right time to give up with non-invasive support and to switch to invasive support with patients on a ventilator. Work is ongoing with that through the recovery research programme. And I think it's really important that we all keep putting our patients into those research programmes, because the UK has done fantastically well at finding some ways through this awful pandemic with improving, finding things that actually work for patients. But I totally agree that what we need to see after this is that close working between the whole team involved in critical care and respiratory medicine, because there is so much overlap and so much learning to get from each other, that carrying on and having enhanced care areas for respiratory medicine, linking them in closely with critical care so that everybody's thinking about the patient and putting the patient in the right place at the right time, and passing them backwards and forwards at the right time for them. And I really hope that that's one of the things that we can hang on to in the future.
Thank you, that's great. Very quick question for Keith from Christopher Beaumont. I think it's just a discussion about the data. Are the mortality rates standardised or crude numbers of deaths?
Yes, so in the first graph I presented, the second slide, the rates were just crude over time, so that was just the crude data. Once we moved on to the later slides, the second last one, which showed the mortality rate for each trust, those were standardised. I think I presented them as the standardised rates of mortality, but we also present them, I think, in the report as the standardised mortality ratios. So those later figures are standardised. And one of the points from the presentation, I think, is that the need to standardise, because so much is changing over time. The profile of patients is changing over time. The management of patients is changing over time. There is a need for this standardisation. The crude figures don't really tell the whole story.
Thank you. So the next question, if I can invite Phil Dyer and Mike Jones, a question from Carol Walgar. Is there a point at which the number and range of assessment tools become a cause for them not being used? For example, the time taken to complete them and identifying the correct one to use?
I think Mike answered it.
Yeah, I mean,
okay, yeah.
Yeah, okay. The issue here is using validated tools, because that actually provides security in terms of your clinical assessment anyway. And it then means that you are trying to make sure that patients are treated in the best way. Yes, there's lots of them about. Yes, we all carry smartphones, and most of the smartphones will carry an app that allows you to calculate most of these assessment scores very, very simply. And so it is a question of, if you think you have come to a diagnosis, then you can actually use the parameters that are applicable to a particular assessment score and get some confidence about how you're managing your individual patients, because we're not using these particular aspects as well as we can to try and get patients out of the hospital as quickly as we can. And I think the pandemic has shown us how dangerous that can be, as I mentioned.
Thank you, Mike. I think, could I ask a next question for Adrian? This is a question from the previous webinar, which we didn't have enough time to answer. So regarding the importance of support for care homes and advanced planning, do you have any thoughts regarding the future beyond COVID-19 for these patients and listed on community hospitals with secondary care?
Well, all this is very much up in the air, but certainly a change in wave one in terms of care home practice was, first of all, of the sites we did the deep dive visit to, as one of the important interventions was support for care homes and advanced care planning from care homes. And certainly during wave one, I think one of the factors in reducing the reduction in mortality during wave one was from the care home sector. We've definitely seen a reduced admission and death rate of patients during wave one, which has sustained in wave two. So I think looking ahead, I mean, the whole issue of community hospitals, support for patients out of hospitals, acute response out of hospitals is really, really key, because we tie up over 50% of the occupied bed days for older adults in the NHS is for patients who stay in more than 21 days. So we've got a huge resource mismatch of patients often being made functionally dependent by staying long periods in hospital. So alternatives, particularly community-based response, community-based rehabilitation in the care home sector, very much linking to advanced care planning and support, are really, really key. And that's certainly, we in GIRFT are looking at that, but it's very much following on from the national plan. Just interesting enough, the data that's just seen from using the frailty identifier tool, which is a tool hospitals can look at how their frailty has managed, is that admissions and occupied bed days are still below, for older adults, frail older adults, still below what it was before the beginning of wave one. So there was, we haven't normalized in terms of that, which is probably a good thing. So possibly indirectly through this, I think the effectiveness of the discharge to assess process probably is key with this, but we have seen a shift, which at the moment seems to be sustaining.
Thanks, Adrian. The next question would be for Jerry Raymond. You gave a talk on the previous webinar about the findings from the diabetic services, and this webinar we're looking at towards the future. What are your thoughts on transformation of diabetic services for the future?
Right, so I think the pandemic has taught us quite a lot. Much of what we already knew, for example, for inpatient diabetes services, there was great variation across the country, and in our GIRFT report, we do address this. We need to have proper multidisciplinary patient diabetes teams. And at the beginning of the pandemic, unfortunately, all these most of these teams were disbanded, and as you know, people with diabetes had a much higher mortality, and we were seeing some very unusual presentations with people with type 2 diabetes developing diabetic ketoacidosis and needing very large doses of insulin. Fortunately, I think going into the second wave, we've recognized the need to maintain these teams within most trusts, but not all trusts. But I do think the importance of diabetes teams present in getting patients safely managed in hospital and getting them out as soon as possible is absolutely key, not only during this pandemic, but in the future. The other important area is supporting perioperative care. We know length of stay for people with diabetes in surgery is really quite excessive, and we know from certain examples that you can reverse that. You can reduce length of stay back to the baseline population. So CPOC has been, the Centre of Perioperative Care has been working on diabetes perioperative guidelines, and those are going to be released next week. So I hope that will do a lot for supporting perioperative diabetes care and working together with our colleagues in pre-assessment, anesthetics and general practice and surgery.
Thank you, Jerry. That's great. And a similar question for Chris Moulton. On the last webinar, we discussed about some of the findings and innovation in emergency medicine from this project. What are your thoughts looking to the future on transformation of emergency medicine services?
Well, I'm afraid that the sort of emergency medicine response to COVID is a bit of a broken record, because really it's just emphasised that crowded A&E departments do actually kill patients. They're very, very bad for patients. In our visits around the country, Cliff and I were very, very surprised by the variation that people had in their facilities. The best A&E departments were protected their patients from viruses with glass cubicles that if you pressed a button, darkened electronically, and had lights that indicated when the cubicle needed cleaning. Most emergency departments protected their patients from viruses with NHS curtains that didn't meet. So really what's needed is complete standardisation of emergency care facilities throughout the country, and really an end to crowding. Thank you.
Thanks, Chris. Could I pose the next question to Anna and possibly Philip if he wants to add anything. What's the role and changes required for critical care in managing long COVID patients and handover to rehab, recognising pressures coming for more elective urgent patients requiring a critical care bed to prevent further deterioration? And that question's from Hayley Citrine.
I think the whole health service is going to be very pressured by the problems of long COVID. We knew before this that patients who'd been in critical care had quite a significant number of them will be readmitted to hospital, and a significant number will die after having a critical care stay, after they've actually already gone home. The numbers that are coming out for patients requiring readmission to hospital after COVID are huge. They're much higher than other disease processes where you get readmitted to hospital afterwards. So that's going to be a continuing pressure on our health service. Getting through the surgical workload, critical care is going to be full of people who are having a long stay after their initial COVID episode. We know that patients seem to take a lot longer to get off their ventilators, a lot longer to wean and start their rehab process before we can get them back to the ward. This is one of those areas where developing surgical enhanced care areas will enable us to get through some of that high workload of urgent major surgery that needs to happen. None of us want to be slowing it down, but it's sheer practicalities. We've got nowhere to put them and nobody to look after them. So we're going to have to work through some of those issues. I'd like to come back before I move on to something that follows up from what we were saying about diabetes. at the beginning of this, people got taken away from other services that actually made the whole hospital work better. So having a diabetes team makes everything work better. It makes surgery work better. It gets patients through medical wards better. And I can understand that you go, oh my goodness, we need everybody doing X. There's a big worry to me that people look like they're starting to do that with their pre-assessment clinics, their enhanced recovery programs, that they're starting to say, we need everybody on the shop floor to start getting through the surgery backlog. But potentially making that response less efficient by not having all of those people who actually make the system hum well. So if you don't bring your diabetes team back, if you give up your pre-assessment clinic, all of those things, robbing Peter to pay Paul is what the NHS does frequently. And we know it helps us through a crisis, but we just need to make sure that we look at everything as the big picture after this, rather than little islands, and how do we make that better?
Thank you. Philip, is there anything you would like to add or on the long COVID side? No. Okay.
Is that you talking to me?
Yeah, sorry, Philip. Was there anything from the acute medicine and acute and general medicine side regarding long COVID and rehab you'd like to add?
No, I think Anna has mentioned it well. I think the important bit is that the readmission rate is very high for COVID, and this is going to be an ongoing issue which we need to plan for. You can't just think it's just a one-off episode. It is going to be a long-term issue that we need to plan for, and what Anna said was quite correct. Yeah, I think there's no more to add to that.
That's great, thank you. And could I maybe ask the last question before we close from Carl Brennan for maybe Prof Briggs and Mike Swart and Chris Snowden, accepting that there is enormous uncertainty around future demand, what should organisations do with regards to changing their capacity? In regards to, I expect we will need more monitored beds than we had pre-COVID. Will this be funded? Do you have any thoughts?
So can I ask Mike and Chris to answer that question?
I can answer
that. I think we're going to need more day surgery. We're going to need more enhanced care beds. We're going to have better preparation of patients. I think we need to have better shared decision making to make sure we don't do wrong patient surgery. Now, some of that will lead to efficiencies that will give you some money to pay for it. But the thought of being able to provide the healthcare we need without additional funding is going to be unlikely. I don't know if Chris...
No, I completely agree, Mike. I was looking at another question actually at the same time, but no, I agree. I think the capacity issue is a problem. We have to make sure we risk assess and prioritise our patients as well as we possibly can. That is an absolute key. So looking across the p-values, the p1, 2, 3, 4, we have to make sure that those are structured correctly and those risk assessment tools are used correctly so that we get the right patients at the right time with the right people doing the right operations and in the right care post-operatively. And what Anna said around enhanced care, we've shown we can increase critical care capacity. As critical care capacity reduces or is not possibly needed, then we can start to look at how we can spread the critical care across the enhanced care and sort of make it a little bit more of a generic process. And then if we really do have problems with long COVID, there is a bit of toing and froing that can be made possible. But I think we have expanded critical care. We need to expand enhanced care within that environment as well.
Thank you both. So we're now coming to the end of our session. I'd like to hand over to Professor Briggs to provide the concluding remarks and close the session. Thank you.
So thanks so much indeed. And can I first of all thank everyone on the call, healthcare workers, for all the hard work that you've performed for the NHS during this COVID pandemic, which has now been upon us now for a year. There's no doubt, though, that we're seeing things improve now because of the lockdown, but also, very importantly, the rollout of the vaccination programme, which I think has been a massive success for the NHS. As we move forward, I think we've got to take the learnings from COVID, and you've heard all the clinicians today speak about their individual specialty and how there has been some transformation of services. If you go back to November 2008, there were 587,000 patients on waiting lists who have been waiting more than a year. By November 2019, we'd reduced that to 2,432. Currently, we have waiting lists of 5 million, and those waiting 52 weeks is anywhere, depends who you read, between 240 and 300,000. And orthopedics, my specialty, is a significant number of those. Now, we've learned an awful lot since 2008. Again, highlighted Mike, Chris and Anna. We've got day case rates now. We want to maximise that 85%. Enhanced care so that we don't have to put the burden on the IC unit. We want to be able to be top decile in length of stay. And also we need to develop hub sites and COVID protected sites where we can get back to work and do the elective recovery that we need to do. What we can't afford to do is this winter is to fall over again. And therefore it's really important that the medical specialties that we've learned a huge amount about, and I highlight what Adrian talked about the frailty, number of patients in hospital. We know it's across 5 specialties. We're already working on pathways through GIRFT to try and help that this winter. We're going to have to maximise absolutely everything we've learned. We're going to have to embed it, and going back to business as usual as we did before COVID is not an option. I think we can get back to where we were. I think the workforce will step up to the plate, but I know they're tired and we need to give them rest and understand about staff well-being. I think there is a role also going forward in a partnership with the independent sector for a period of time to help us get through the backlog, because at the end of the day, what's imperative is that patients are treated equitably, fairly, and they get their procedure when they need it. And I understand that MDT working, shared decision making, etc. I think that is going to be really important, as well as preparing our patients for surgery and getting them up and mobilise them home as quickly as we can. But I think there is a will out there to do that. And I think we have a real opportunity to serve the population that we of this country. We have a fine NHS and we need to step up to the plate, which I think healthcare workers have shown they've done over the last year in absolute spades. So I look forward to working with everybody. There's no doubt we're going to learn a lot more about this COVID disease as we move forward, and therefore there will be further guidance about how we manage it in the future. But I think that what we cannot be is an NHS as a one-trick pony. We've got to get back to business as usual, but we will have to do things in a transformational way. But I look forward to working with you all to help drive that we can provide the care we need for our population. So thank you very much.
Thank you. We'll now close the session. Thank you.